Apologies to those of you who already know all of this information, but we feel it's important to kind of set up the context of authority and scope that the value plans are part of, so that we can all be on the same page. So as you may know, MHBE is the state-based health exchange, launched in accordance with the ACA in 2014. We operate an enrollment platform called Maryland Health Connection. Consists of a website, app, and call center. We serve most Medicaid enrollees who are, determined based on their income for eligibility for Medicaid, and then enrollees in the individual market as well. So you can see on the slide some of our current enrollment numbers. And to enroll in the individual market, an enrollee cannot be eligible for an affordable employer offer of coverage or for Medicaid or Medicare. And then the exchange is the only way that private plan enrollees can access financial assistance. They can't access it if they enroll off exchange directly through a carrier. So the subsidies to be aware of are the federal subsidies, the premium tax credit, which caps the expected contribution at a certain percentage of income. And then we also, there's also reduced cost sharing for low-income individuals, which we'll talk about more later if anyone's unaware. And then the state premium assistance program for young adults that is specific to Maryland, our young adult subsidy program, which you may have also heard of. Within our scope is outreach and enrollment activities, such as the Navigator program. We also work to enhance our enrollment platform to improve experience for consumers. And then we set every year plan certification standards. So this is kind of a policy tool for us to kind of establish certain features that we want to ensure that plans have, having to do with plan design or certain information that's available for consumers, that kind of thing. And then we also administer affordability programs, including the reinsurance program and the young adult subsidy, which I've already mentioned. And for those of you who are new and have questions, please let me know at any point. So in general, MHBE's purpose is to reduce the uninsured rate in Maryland, and we do that by facilitating the purchase of QHBs, or we call them private plans, when we're communicating about them in the individual market, and then also to assist individuals in accessing all of the public programs. Those are the kind of relevant purposes to this group. Our affordability initiatives, the reinsurance program and young adult subsidy. So the reinsurance program, for those of you who don't know, basically we, as the state, reimburse insurers for a portion of high claims costs. So if a consumer or a patient incurs healthcare costs over a certain dollar amount, then we begin reimbursing at a certain percentage until they hit a certain cap. And so by reducing the cost of covering those individuals to insurers, they're able to pass those savings on to consumers in the form of lower premiums. We intended to stabilize the individual marketplace with this program when it began back in 2018 and reduce the premiums across the market, and that is what we've achieved. Rates are down more than 20% compared to 2018, and enrollment is up. The young adult subsidy is our other large affordability initiative. It's a pilot at this time, so it's slated to sunset in 2025, but it's a state-funded premium subsidy, and it reduces the amount that young adults pay for health insurance. So but the amount of the subsidy is based on age and income. So we have charts and things that I could provide if anyone's interested in more information, but essentially the youngest and lowest income people pay the least towards their premiums. Yes, David.
Just real quick, it's 18 to 37 this year.
Yes, thank you. Yes, we changed the parameters for this year. They are going back to 18 to 34 for the final year of the program, but that is important to know. So the goal for this program is to improve the risk pool and reduce premiums overall by having young adults who are healthier than the general population that's enrolled in private plans. It brings down the cost of insuring everyone and reduces premiums for all. And also young adults are a population group that is disproportionately uninsured. So it's a win-win. We have over 44,000 young adults enrolled right now, and the average subsidy is $38. And that's on top of any federal assistance they might be receiving. So our enrollment in the young adult subsidy population is up 41% year over year, which far outpaces our overall enrollment growth. And then young adult enrollment constitutes 21% of our total enrollment, which is up from last year. So very successful program. And just important to know that our efforts are working. In general, Maryland's premiums are lower cost than other states. And depending on metal level, the lowest cost plan is between 25 and 35% lower cost than the US average. So value plans are essentially plans with standardized cost sharing, and that cost sharing is determined by MHBE. And so benefits, essential health benefits, are already kind of determined by state and federal governments, but the cost sharing varies sometimes significantly by plan, and that's sort of regulated by metal level and actuarial value. So in terms of plan generosity and category of plan generosity, but in general, unless the plan is a value plan, the cost sharing is not. It can vary across plans. So our goal with value plans is to have plans that are the same in terms of cost sharing for different services. So value plans, carriers must offer one at each of the metal levels, except for the platinum level. We don't have a value plan at the platinum level, but for bronze, silver, and gold, we do. And I mentioned actuarial value. We may end up talking more about this later, but just so that everyone knows, actuarial value, as I mentioned, is a measure of plan generosity. There are federal requirements for the generosity of each metal level, and we can't vary outside of those federal requirements. So actuarial values usually is represented as the percentage of healthcare costs that an insurer will cover, and then the remainder is up to the consumer to pay for. So for bronze plans, it's about 60% covered by the insurer, and so on. Every year, the federal government releases the actuarial value calculator, which we use to ensure that plans comply with the federal limits on actuarial value. So the actuarial value that a plan must have, there's a small range around that 60, 70, 80% that's listed there. It's not exactly, it doesn't have to be exactly that actuarial value, but we call that the de minimis range, the range within which the AV must fall for a plan to be considered a given metal level. And this is important because one of the kind of defining pieces of information for this group, the thing that we will be coming up against a lot is these restrictions on AV, and the fact that we have to make trade-offs, because ideally we would want to be able to offer very generous plans and include free cost sharing for certain conditions and types of coverage, but ultimately we will be coming up against these restrictions, and if we reduce cost sharing for one service, it means we'll have to increase it for another. So it's just a really important piece of information that everyone should be on the same page about. And in general, our goals with the value plans are to improve access and affordability of healthcare. So in addition to standardizing the copays across carriers, we do this by dictating pre-deductible coverage. So deductibles these days are pretty high, so it's important for people to be able to use their plans right away without having to hit that deductible first. So ensuring that there's pre-deductible coverage of common services is important. Choosing copays over co-insurance, you'll see most of the services, most of the cost sharing is a copay for the value plans and not co-insurance. As you can imagine, it's easier for people to budget and imagine how much their healthcare will cost them if it's a copay and not a co-insurance, because they're not going to know necessarily how much the service will cost. And then we can also promote health equity through plan design, which is something we'll talk about a little bit more later. And it's something that for those of you who know about our health equity work group, that's something that they talked about. And then it promotes juror competition by encouraging this kind of apples to apples plan comparison. So people are more easily able to pick a plan based on which carrier they like or the network versus some slight variation in cost sharing. It's just a factor that simplifies the plan shopping experience. So as I've mentioned, this work group falls within a legacy of MHBE work groups, MHBE work group cinematic universe. So in 2019, we started out with the affordability work group, and value plans were a recommendation of that group. At the time, we didn't have this piece of standardized cost sharing, but they included things like deductible caps, copay caps for certain services, certain diabetes supplies being covered at $0 cost sharing. That's how the value plans started out. And then as the years have gone on, we've made changes. The health equity work group recommended including cost sharing for reduced cost sharing for high disparity conditions like diabetes. That's where we started with that. Then by 2022, we were talking about standardizing the value plans, and that was ultimately the recommendation of the affordability work group. And also to limit the number of plans that carriers are allowed to offer per meta level. And that won't start till 2025. But one of the things that we talked about in past work groups is this idea of choice overload. If there are too many options, people will people are more likely to make a suboptimal plan choice if there are too many plan options. There's research supporting that. So by limiting right now the number of plans the carrier can offer per meta level is 4, but for 2025 and beyond it will be 3. So 1 value plan and then 2 that the carrier has the discretion to design themselves at each meta level. So 2024 this year is the first year in which we've had standardized value plans. And then for 2025, we hadn't had a chance to see how the plans did in 2024. So we made minimal changes. And yeah, just another little reminder that the plan limit will be effective for 2025. And so what we're doing here is planning for 2026. And so again, for those of you who aren't used to this type of work, this spreadsheet is an example of the product we're going to end up with at the end of this group. So it's going to be, a list of services on the side, and then the cost sharing amount that, no matter what carrier it is, that will be the cost sharing amount for the value plan for that service in each meta level. And we have indicated in blue, like that's a pre-deductible coverage and so on. So if you want to take a closer look at this, the 2025 standards are something that I included in the email in advance of this meeting. So feel free to take a look at that. I also wanted to highlight the diabetes cost sharing that we established starting in 2024, but this is specifically for 2025 plans on this slide. But essentially, we consulted with Washington, D.C., who has already been working on this cost sharing for equity sort of work, and also with clinicians and so between all that consulting, we were able to come up with this list of services that are generally used for in a year of managing type 2 diabetes. So the idea is, to eliminate the costs associated with managing type 2 diabetes, which disproportionately affects communities of color. So this 2024 is the first year that we did this diabetes cost sharing at this kind of scale and put this much thought into it. 2025, we clarified some of the specifics around the supplies and prescriptions that carriers must cover. So we clarified that the $0 cost sharing includes test strips and glucometers. It includes preferred brands of insulin, and it also includes certain oral hypoglycemics. And then here's just another way of visualizing value plan standards. And this is for 2024, but we'll make another chart along these lines for 2025 and all plans, all years subsequently. But you can see how, the co-pays are listed there, which I'd like to compare to the 2023 standards, where you can see, for bronze, no deductible requirement, but for silver and gold, there's deductible cap, and then kind of services that must be covered before the deductible, but not necessarily a specified copay, that kind of thing. So you can kind of see how we've evolved from the 2023 designs. I want to highlight the kind of changes in enrollment that we've seen in value plans since their inception. So we saw an increase or kind of steady enrollment in value plans since 2020, but in 2024 we've seen a bit of a dip in enrollment. It's still kind of hard to tell exactly why this is happening, and so what we can do as a work group is to kind of just think about ways to make the value plans, make the value of value plans as clear for consumers as possible. So one of the ways that we kind of can encourage value plan enrollment is through our plan shopping tools. So we already kind of do some things like that, but this is just to get you guys thinking about ways that we can kind of share the value of value plans. So we already have a way for people to filter by value plan when they shop for plans. And we also require that value be in the plan name. And then also we have a little flag on plans that are value plans. But there are many other kind of things we can consider in terms of designing the plans. So overall, our goal is just to update the value plans for 2026. And within that, kind of keeping in mind cost sharing that promotes affordability of common services, but then to not exceed the actuarial value constraints, and then talk about the extent to which we are able to promote health equity with the plan designs. And so that'll be the topic of conversation. We will also, as we're talking about the plan designs, be considering some suggestions that we received during the comment period for 2025 plans that we weren't able to incorporate at that point. And they will make more sense when we are talking specifically about plan design. So I won't read through that now, but just to kind of put a pin in it so that you all know that it's coming back. And yeah, I just want to kind of give it over to you guys. If you have any thoughts, initial impressions so far, questions. I think the main thing that we should be thinking about is this trade-off between reducing cost sharing for other high disparity conditions versus keeping copays for the rest of coverage affordable. DC, and I'll talk about this more at our next meeting, and some other states, every year will add, they started with diabetes, but add hypertension or pediatric mental health or asthma, and reduce the cost sharing for a new condition each year. And so that's something we could consider, but it's also, with everything we add, we have to hike copays for other services. So I'll stop talking. Thank you for listening, and let me know if you have any questions. Lisa.
Get myself on the mic. I just wanted to make one comment where you said you saw a decline in the value plan. The United Healthcare on the bronze level does offer a zero deductible plan that allows them to get access to like MRIs without having to meet the deductible, even though it has higher co-pays than the value plan. To me, that's more valuable because in case they had to get an MRI, instead of paying $1,500 on that zero deductible bronze plan from United, it's only $200 for an MRI. So I opt for that over the value plan. So that might be one reason where you see a decline if it's in that bronze level with that.
That's a really good point, and
Yeah.
definitely something for us to consider, because that plan in particular, but then in general, it might be the case that there are certain, whether it's the premium level or the deductible level or certain types of coverage that are available at a lower cost sharing that are seeming more attractive to consumers than the value plans, and that's important for us to consider, definitely,
Right.
as we design the value plans. Yeah.
Also, I think it's based on like health necessity as well, because it's $150 for a specialist visit on the plan I'm referring to. So if they do see a lot of specialists, that may not be an option. But if they're pretty healthy using normal things and like they may see a specialist, but there's a chance they could break their leg or need an MRI, I think they feel safe knowing it's $200 versus having to meet a full deductible of $1,500 before they can get an MRI. So
Sure.
that's my comment.
Yeah, that's a really good point. David.
I would agree that I think in general, the bronze plans were more attractive this year. And I also think that I'm also a certified navigator. And while it's not my main function, it's easy for plans. When we have a smaller number of plans to choose from, I think the value plans will stand out more. There's a lot of plans to weed through right now, particularly in silver category. And I just feel like when we winnow things down to 3 per metal level per carrier, I think the value plans will stand out. But I agree with what was just said. I think in general, bronze plans are more attractive this time around.
Interesting. That's definitely something I'll look into some more. Is there, you think, does anything come to mind as a specific reason for that, other than what Lisa has already mentioned about the $0 bronze deductible plan? Or
well, just in general, there was more pre-deductible care in a lot of the plans. The premiums were lower, right? And for younger, healthier folks, bronze made, who go once a year or something along those lines. And we are bringing more younger people in. I notice a lot of younger people were picking bronze plans.
Interesting. Yeah. That makes sense. Matt. Yes.
So Becca, I was curious if the exchange or MDH or both had done any analysis about unwinding, and if some of the folks that had turned off of Medicaid because of redeterminations might not have chosen a value plan because they had a robust subsidy that might have got them to buy a more generous package, and maybe that had led down plans.
Yeah, that's such a good point, and definitely makes sense as a hypothesis for one of the reasons why we're seeing what we're seeing. I don't think we've done an analysis on that specifically, but it's definitely a good point. And I can also do some asking around to see if we have anything.
I was just thinking that it's not necessarily a awful thing that the enrollment and value plans reduced, because it might mean that people are actually getting better coverage unfortunately, because of their lower income status.
Right. Yeah. No, for sure. That makes sense. Yeah. And then it's interesting to think, I guess, if those people were eligible for like a high AV silver CSR plan, why would they go with assuming that it's the case that maybe they've gone for a non-value plan version of that Silver 94 CSR plan, why they would have done that versus going for the value plan.
And I would imagine the people that were on the margins that were redetermined out, like the majority of them are probably on gold plans, right? I mean, I would guess. That's just my idea.
Yeah. And a gold plan is definitely, better value and usually about the same price as a if the person's eligible for the least generous Silver CSR tier. So that's a good point. David.
I just want to add to that I think it is a challenge for us to get across cost sharing reductions and the value of cost sharing reductions when the premiums are equivalent, right? And like, or the premiums, I should say, for some of the plans with the cost sharing reductions are higher, right? And I think it's been a perennial issue of what you pay per month is not necessarily indicates what you're going to pay over the course of a year. And I just think we have to come up with better ways of educating consumers so they really understand the value of cost sharing reductions.
Good point. Evelyn.
Thank you, Becca. And David, it's always so interesting to hear you. I served on the work group with you before, and you were always just so encouraging and had so many great ideas. So I love listening to you. But I want to switch to point number 2. Well, I guess it's the first bullet under questions. When we talk about adding a 0 reduced cost sharing for high disparity conditions, do we have any data to show how our patients perform, or well, they're not patients for you, but enrollees perform with those disparity conditions? Right now, I manage for the quality metrics for my medical group. And the biggest challenge we have is for patients with hypertension and diabetes to be compliant, trying to get those numbers within, acceptable range, moving them from, full-blown diabetes type 2 to pre-diabetic and then to non-diabetic. That's a challenge for us. They physician hop. They don't typically stay with the provider to see the improvement in their numbers. So do we have any data that shows that it would be beneficial to reduce to a 0 or reduce cost sharing for high disparity conditions versus just keeping copays low for all of the patient populations?
That's a good question. Not that I'm aware of. I think there may be 2 reasons to eliminate the cost sharing, and one could be to change patient behavior, and then the other one would just be just because it's more equitable. And so, that's not something that I have kind of evidence for. That for the first point, whether it changes patient behavior, I think the theory is that it would. Another thing to think about is kind of the amount of time that these kind of, these kinds of interventions take to show progress in the data. We've been collecting for the reinsurance program. We every year collect accountability, what we call accountability reports from the carriers. And we are interested in whether any of their care management initiatives have an impact on the cost of care. And some of those initiatives have to do with diabetes management. But what we've seen is that year after year, the time scale is maybe too small to be seeing changes and to be seeing impact in the form of significant cost savings. Also considering the size of the population because this isn't like the entirety of Maryland. It's just a more specific subset of enrollees. So yeah, that's a really good thing to consider. And yeah, I guess it would help us decide whether it's worthwhile to add more high disparity conditions if we could point specifically to data showing that it improves outcomes and reduces costs. But yeah, in the absence of that, we have to kind of maybe make our decision another way. But one thing we can do is look at the experience of other states who have added more conditions and see what they're learning. And that's something that I can bring to a future meeting, is a little more information on that, I think, learning from other states. Yeah.
Thank you, Becca.
Yeah, I hope that was helpful. David.
I just, along those lines, I always, people just bring who they are to their healthcare providers, and it's rare that you see somebody with diabetes or pre-diabetes that doesn't have other things going on. And there's the interrelatedness of all these health disparities. And I don't have an answer for this. I just would encourage, I would like for people who are much more steeped in the actual healthcare side of things and plan design, is there a way that we can have, instead of picking out one specific condition, but or sort of have a more of, I don't know what you would call it, an equity focus or a more holistic approach, rather than you have, I mean, honestly though, I think diabetes is clearly one of the most important things. I think what's been done there is well worth doing, but I just sometimes feel like you pick one at the exclusion of the others, which is sort of what we're talking about. And if there's a way to make plans a little more inclusive of and recognizing all the interrelatedness of these conditions, and one leads to the other. I mean, heart disease and diabetes up here where I live go together big time.
That's a good point. Emily and then Evelyn.
Hey, I think that because of that disparity with the high disparity health conditions, because we have things like diabetes, we've got cancers, we have renal failure, we have HIV, we have hypertension, we have so many of those conditions. I think that's one of those things that actually speaks a little bit more sometimes towards keeping the general copays low, because they're going to have so many different services and so many different specialists that they need to see. And there's no predicting what your comorbidity is going to be. You've got things that have been sort of coming up more and more, like certain syndromes, like Ehlers-Danlos syndrome, which is connective tissue disorder, that we're seeing diagnosed more and more. And that affects the whole body. So if we're thinking holistically, it's hard to pinpoint which disease is worthy of having, those $0 reduced cost sharing, and which aren't. But I think when you're talking about those types of things, it is sort of beneficial to think, if you're thinking holistically, that there's greater equity in keeping general costs low, because people are going to have multiple appointments with multiple providers and specialists and need labs and MRIs and imaging, and all of those add up very quickly.
So true. And that's something that I think maybe Washington has taken this approach in their standardized plans, where I think it's maybe only the first 2 visits, but for primary care and mental health care, they're doing $1 copays for the first 2 visits. So that's an approach we can think about as well. I like that as an option. Thanks, Emily. Evelyn?
Thank you. Emily, I completely agree with you. And David, you're right. Multiple comorbidities absolutely are a huge factor with the quality metrics that I'm required to, decrease or show improvement in. And it's really difficult when you talk about diabetes. I was hearing feedback, diabetes, hypertension, and high BMIs, they all go hand in hand, and it's really, really difficult to get the patient to lose the weight, which impacts the A1C, which impacts the high blood pressure. So it's all working hand in hand, and the willingness of the patients or the discipline of the patient plays a huge factor in, and also socioeconomics has a huge impact as well. So I'm with Emily. I think, keeping copays low because they have endocrinologists, they're trying to go to dietitians, they're trying to go to their primary care providers, especially when the A1Cs are out of control and not being able to be controlled. Those are appointments that are going to be necessary. So I really am thinking that copays being low for all of our, enrollees would be the better way to go.
Thank you. I'm hearing a lot of agreement on this idea that keeping copays in general low is helpful in terms of and possibly equitable in a different way so allowing people with comorbidities to manage all of the conditions that they may be experiencing. Justin. Oh. I saw you with your hand raised, and then, we lost you.
Now I'm off mute. I would say I appreciate all those comments, and I think I probably generally agree with them. But I would say, I mean, some of what we're doing here, right, is the math problem and the trade-off. So I think it might help, and I'm sure this is where we'll be going over the next few months, is to start to unpack this and with some specific examples, because granting that for sure there are trade-offs that will need to be made to get it under the AV requirements, it may not be the case that it's simply raising copays for everything in order to provide this one break, right? I mean, there are lots of ways we can play around with this in order to perhaps provide a greater help for a particular high disparity condition without necessarily creating widespread burdens on everybody else. So, I mean, I think, to the extent that we're able to have, I'm curious in terms of some of the actuarial work that hopefully might go into this in order for us to figure out what those trade-offs really look like concretely. I think that would be super helpful.
Yeah, and we'll absolutely get into that. Yeah. Tim.
Hi. As I sit back and I listen to this discussion about, like lowering cost sharing for some of these at-risk individuals to try and encourage, better compliance, it struck me that, I mean, because I come from an underwriting background, and I know that that sure, cost is obviously a huge factor in terms of, compliance and things like that, but it's not the only one. I mean, a lot of these folks are impacted by other social determinants of health. I mean, you're looking at transportation difficulties, all, coordination of care, other types of things that are a little bit less discreet than just, playing with levers on the cost share wheel. So I don't know what types of discussion you guys have had, or what types of flexibility that we might have in the future to look into, ensuring compliance through enhancing other factors like those.
That's a great point. Yeah, cost is definitely not the only factor. Allison?
Yes, I think with regards to $0 cost sharing, the other thing we need to keep in mind is that especially when we target it by chronic condition, we start getting into identifying specific diagnosis codes. And so from an administrative perspective, it can get really complicated. And in some cases, it depends on the provider listing the diagnosis first. And if that doesn't happen, then the patient doesn't receive the reduced cost share. So I just want to caution that it does get really complicated depending on the condition and the specific service. And then the other thing I just want to note is that we want to make sure whatever we're looking at is consistent with EHB non-discrimination rules, which prohibit discrimination based on age and chronic conditions. So just want to keep those 2 points in mind as we kind of look at some options for that second bullet.
Yes, good point. And Allison, I guess, and you don't have to answer this now, but based on your experience with DC, since they have many added many high disparity conditions, so is your kind of perspective that it's complicated from an administrative perspective to implement that? Does that come from your experience there, or would you kind of advise against that approach?
I think we're still working out the member experience from a coding perspective. You know, it's not complex there, but it's rather the patient experience. Like others have mentioned, you know, diabetes often is paired with other chronic conditions. And so if someone goes in, say, for a PCP visit, and they have a diagnosis code of diabetes, if that's listed first, then the cost share is $0. But if, let's say, asthma or hypertension is listed first, they wouldn't receive that, at least in the kind of first year of those standard plan designs. So I think that's where we really get into, you know, the risk of just it not working out administratively, just by the nature of how those visits are coded. And that could introduce, you know, patient frustration. And the other issue is that we don't have a way of communicating these benefits in the summary of benefits and coverage. So that document is, it's mandated by the federal government, and we don't have any flexibility to add certain line items. And so it's just really difficult to communicate that these benefits exist. And so that's another challenge.
Gotcha. Okay. Makes sense. Okay, so I'm hearing we want to kind of be learning more from other states. So I'll be bringing that to an upcoming meeting. It'd be good to hear from someone with a kind of holistic approach or an equity focus from the healthcare perspective, in part because of comorbidities being a big factor. And also this means possibly keeping copays low in general would be helpful. For that, also hearing, just because that might be a good idea to keep copays low, and you kind of, if we're having this kind of, we're looking at this as two competing options, we might not necessarily need to think of it that way. It doesn't need to be keep general copays low versus reducing cost sharing for high disparity conditions. We could maybe also see if there are some lower lift conditions that we could reduce the cost sharing for that wouldn't have a huge impact on AV. So it doesn't have to be either or. We can kind of look at both a little bit. And that's something else we can learn from other states, perhaps, see if there's some sort of kind of low-hanging fruit that from a population health perspective would be really helpful to just include also along with diabetes. And cost isn't the only factor, looking into maybe other ways, maybe in our scope to look at social determinants of health or coordination of care, something to look into further, whether that's within our scope. And then thinking about the patient experience and how we are kind of limiting the reduced cost sharing by diagnosis code, whether that's a good idea or not. Thinking about discrimination, thinking about how to communicate the details of the plans when we don't have flexibility in SPCs. This is really, and then also earlier we talked about the attractiveness of the bronze plans this year versus the value plan bronze, and how we should be thinking about the attractiveness of these plans compared to what's already on offer. Yeah, this is all really good stuff. Does anyone have any other comments right now? Okay, I think I'm going to talk about our next steps really quickly, and we'll have a public comment period a little bit later, but I'm going to skip ahead to the next steps just in case anyone has any thoughts on that. So, like I said, we're going to vote on the co-chairs and the charter via an online survey that I'll send out after this. Our next meeting is in 2 weeks. I'll use some of the information that you guys have brought up today to kind of develop something for next time. The bulk of our regular meetings are going to be kind of June, July, August. I think having the intention to have our actuaries draft some plan designs for mid-July would be good timing wise. And so that way we'll hopefully be able to get started on the early side in terms of looking at the specifics. And then we'll workshop those plan designs until August, finalize them, and then reconvene later in the winter after the EV calculator has been published. If there are no thoughts on that, I think we can have our little public comment period. So anyone who's not a work group member, or even work group members who have other thoughts, feel free to raise those now.
Hey, Becca, this is Adam with the Maryland Insurance Administration. The one comment I would make about the AV calculator, so they usually don't come out, I think, the draft versions until November. And so, I mean, if the work group, there may not be any changes that are needed for cost shares this year, I guess for next year. Because every year the maximum out of pocket changes. And I mean, obviously that's going to be a work group's decision on if they want to increase the maximum out of pocket to whatever the maximum is. It was just, since the ACA started, the maximum amount of pockets increased every year. And then for this year, I guess for 2025 plan year, they decreased it. So in order to meet AV ranges, with the decreased maximum out of pocket, we had to increase cost shares for some other services to reduce the AV to get it in range. So, I mean, I don't know if anybody federal government will give guidance later this year as to what the maximum out of pocket is going to be, but there may not be any changes needed for copays or co-insurances if they do increase the maximum out of pocket.
That's good to know. It'd be convenient if we don't have to change anything as a result of the calculator coming out. Okay, I think I'm not hearing any other public comments. So that's all I have for today. I really appreciate everyone's thoughts. It's really helpful as I think about where we're going to go over the next couple of months to get input from you all. Feel free to share, email me at any time with your thoughts. I'm just glad to have such an engaged group on board. So thank you so much for joining. And I think we can close out for today.
Thank you, Becca.
Thank you.
Thank you.
Thank
Thank
you.
you.